everyone. Sir, thank you so much for this opportunity. When I came into this hall, I thought it's the wrong hall. Can't be SICS. So I have to congratulate, sir, you and the whole team, Dr. Sahu, sir, Dr. Boramani, sir, and Dr. Gogate. I don't want to forget Dr. Purvi, and everyone for just doing an amazing job of bringing this surgery to the limelight. So I'm speaking on Frown versus Chevron, but it'll be mainly Chevron because 20 years ago I started with Frown, and I decided I don't like a Frown much. So we made a Chevron. If you're seeing me standing here, you may be wondering, why her? Why is she talking about Chevron? I may have been doing the surgery for over 20 years and teaching it, but it is the generosity of the ISMSICS chairpersons and founders who have allowed me to be here and to share my journey with you. So we have a lot of publications and ongoing research and publication also. We cannot ignore the issue of affordability in our country. We cannot shut our eyes to the underprivileged and the magnitude of suffering humanity and people with advanced cataracts who come to us. I'll show you a picture of our OPD after this and all the cataracts. So it is affordable, it's effective, and I do not know anybody who has changed during the course of a surgery from phacoemulsification to, who has changed from SICS to phacoemulsification. I'm having problems in SICS, let me convert to phacoemulsification. Whereas, I do know people who have changed from phaco to SICS, just like I changed from high heels to flats. I do not change from flats to high heels if my feet are hurting. So it can be done in any cataract at any stage, shorter learning curve. There's a beautiful simulator experience that is available, which my PGs have experienced, and they have become very good surgeons after that. Cost is minimal, and you can do it in camps and high volume due to the technique. This is our typical tunnel, which I have improved now after this last publication. So I never did the straight incision because I was told at the beginning Frown is better. I started with the Frown. I realized Frown is giving me 0.8 to 0.1 diopters of astigmatism, so I decided that I have to reduce this, went on to the Chevron to keep it within the neutral astigmatic funnel. So irrespective of the preoperative astigmatism, my experience is that you can still use the Chevron incision for minimal surgically induced astigmatism, and in the year 2022, in our latest series of cases, it is 0.32 diopters plus minus 0.27, which is comparable to anywhere else, and I don't do the keratometry or the post-op refraction. Somebody else does it so that I'm not biased in my cases. Everything is recorded. So all the studies show that Chevron is a good incision. Of course, we know that the size, location, shape of incision affects it, and sir is doing on axis, Dr. Boramani said, Dr. Sahu is doing 2 millimeters. They are magicians. You can start with this, you can try to dream of reaching that stage later, but at least do the best you can. So this is a typical patient who's come, 78-year-old gentleman with hypermature cataract. So I'm trying to keep why we have reduced our astigmatism over the past few years from 0.56 to 0.32 is because now I'm going further away from the limbus. Instead of my usual 1 to 1.5, I'm now 1.5 to 2 millimeters away from the limbus. And the tunnel, as you can see, is ideal. Whatever the staining of anterior capsule is very important in these patients, especially the hypermature. People said you don't do a CCC in SICS normally, so I've shown all CCCs. Even in this calcific cataract, you can see all the stars in the eyes and on the anterior capsule, all the deposits. The CCC has been, and this nucleus actually cannot be rotated into anterior chamber. It is so voluminous. So I had to take an irrigating via vectus behind it to remove it in toto. And this is the end of the surgery. Another similar patient. Again, you see all these incisions. I have measured them. Not too much cautery, not too little cautery. Not too deep tunnel, not too superficial. If you go superficial, you'll have buttonholing. If you go deep, you'll have premature entry, which never works, and the astigmatism goes for a toss. So again, the same thing. The total cost of the surgery is less than $10 US to the patient, and if the patient can't afford it, I sponsor it. Because nobody deserves to be walking around with an advanced cataract if they reach us as ophthalmologists. Again, so you can see the tunnel. You can actually measure them, and I'm showing CCC in all these patients because I have this tunnel to work with. I find that the forceps is easier in intumescent cataract, white cataracts, and in hypermature cataracts. So after the hydrodissection, irrigating via vectus is very effective and useful, and IOL can be implanted in the back. This is another person. Okay, this is a recently done case in a younger patient. Younger, I mean less than 70, who come to me because all my patients are middle-aged. They're above 70 years of age. And this is a younger patient, so I made this 2 millimeters. As you can see, it was actually 2.5 millimeter away from the limbus, which I thought, like, will I get away with it later? Because my crescent was being utilized completely in the side pockets. You can see the whole crease and you don't need to measure it. It is going there. This person here, 4 millimeters, 6.5. So there was, why I chose this person is the pre-operative astigmatism was 0.25 diopters with the rule, and post-operative induced astigmatism was nil. We have a lot of patients like that now. So he's walking around with 6/6 unaided vision. So uncorrected visual acuity is a big factor. And these are the post-operative results in case you feel, you just left them like that. 1 or 2 have a small air bubble, so you can see the first post-op day. And the mean surgically induced astigmatism now is 0.32 plus minus 0.27. And these are our expectations, 1:1, doctor-patient ratio. This is reality. This is an actual picture from our OPD. This was taken 2 weeks ago. There are people standing on top of people, but our reaction to this, we are grateful, we are blessed that we get so many people who come to us. They bring more people to us. Sometimes they go to another doctor and say, yahan nahi karana, iske paas aao. So you're really blessed for that, and you cannot fly, crawl, or go through this space. Once you're in your OPD, you don't leave until OPD is over. And I'm still learning to provide quality to quantity, and I'm learning so much today. Thank you so much, sir, for this opportunity. Thank you.
Good teacher, and she is a HOD. You have become HOD now?
Sir, I'm head of glaucoma.
Ah.
HOD is under consideration. Hard years are going on.
Okay, she is very dynamic, and we are happy she is here.
Hopefully you will be there. Next speaker.
Even otherwise, I'm
Paper is there.
Ma'am will be coming over the consideration. Under consideration will be coming over.
Actually,